on the 12th of December 2018. The title of our episode, Medicaid Kentucky Style. It's about the Commonwealth of Kentucky and how they have addressed the issue of Medicaid. And when we're finished here, we have a program from the Kentucky Public Television Authority, where there are a number of panelists there, the progressive legislator, Mackenzie Cantrell, and a gentleman from let me just make sure I get his straight here. One of the think tanks in the state of Kentucky. I just finished reading it here. It is the Kentucky Center for Economic Policy. And it was Jason Bailey was part of that production there. And what is interesting is this whole Medicaid issue and the waivers, Kentucky being one of the states given waivers. We'll get to Arkansas also. This is bigger than just the Commonwealth of Kentucky. Arkansas is there. Indiana has their policy, and also, and even Ohio, when it comes to food sufficiency, are the what used to be euphemistically called the food stamp program. All of these programs have been saddled with work requirements that people either perform public service or that they are available for work for a certain number of hours. And the problem is that as pointed out in the presentation on the Kentucky Public TV, that most of the people there are already on or work, Medicaid recipients already work. And the others are disabled and cannot work. But the numbers are staggering, the number of people that have been taken from the rolls in the state of Kentucky. And this also brings, as the Chicago leader, Jesse Jackson, the leader of Operation Push, has always talked about jobs. And yes, in slavery, African people had jobs. But there were no benefits there, and there was no development. And this is all about development. There's a nice article here from the Kentucky Center for Economic Policy. Kentucky's economic performance falls short of claims based on corporate announcements. This was on the 10th of December by Mr. Bailey. And let's first go to the other study. They've done more than just one study here. Oops. And we need to find it because they have so many of them. We'll look also at Arkansas here. We were the other night we did this. Anyway. Let's go to Arkansas's Medicaid work requirements could cost thousands coverage in the state of Arkansas. They talked about this in the public TV roundtable discussion, and this is was released on back actually in August, but nonetheless, this is data from the state of Arkansas. Shows that 5,426 people were in their second month of non-compliance. Excuse me. This is a part of the Arkansas effort there, new work requirement, putting thousands at risk of losing their health coverage, and it went into effect in June, and it was approved by the Trump administration. In July, the second month of the work requirements were in effect. 12,722 people either failed to report their activities to the state or did not meet the 80 hours a month requirement. The vast majority of these 12,000 people didn't log into the state's website. Now in Kentucky, they'll say, well, we have a mobile website in Kentucky. The vast majority said they were meeting similar work reporting requirements under a SAP, that's the Food Stamp Program. Overall, the state said only 844 people required to report their activities to keep coverage reported at least 80 hours. That's quite a few hours there. Now, the National Health Law Program filed suit against Arkansas and a number of other states on the SAP requirements. And in June, a federal judge did block a similar work requirement, a Medicaid work requirement, in Kentucky. So we've had a lot of court action around these various situations. Now, the Arkansas challenged the state Medicaid work requirement. This is on August the 14th. This is from the Health Law Organization. A federal lawsuit today lodged in the District of Columbia. Arkansans are challenging the approval of Arkansas' requirement to condition the receipt of health coverage on an ominous work requirement. According to the lawsuit, the Department of Health and Human Services acted in an arbitrary and capricious manner when it approved the work requirement in violation of federal law and the Constitution. The Arkansas waiver plan has it all backwards, cutting people's health care and making them jump through administrative hoops. Mackenzie Luttrell mentions this, Cantrell mentions this in the discussion about red tape, hoops, that sort of thing. That's an old scheme that goes back forever. As LBJ would say, when Christ was a corporal, it's hard for our clients to work and make a better life. It's not easy. That is from the legal aid attorney in Arkansas. 60% of people covered by Medicaid expansion in the state already work, and nearly all of the rest have disabilities or look after a family. And they go on to talk about the plaintiff. We won't spend time on that one, but Medicaid is not a work program. It's a program to provide health care coverage. Medicaid coverage entitles people with limited incomes, no health insurance, to become healthy without access to health services. It's nearly impossible to be healthy enough to find and keep a job. That's very important. You can't be employed if you're sick. In June, a judge vacated a similar scheme that was in the state of Kentucky. The group challenged the Kentucky waiver, the National Health Law Program, a Kentucky Equal Justice Center, and the Southern Poverty Law Center were some of the people that challenged that particular rule in the state of Kentucky. Let me just move along a little bit here and get to, okay, this was the night. This is the center. Reinstated SNAP timetable has led to thousands without time limit, has led to thousands without food. This is from the center also. Since May, 10,000 Kentucky adults have lost their food assistance as a result of a new barrier to SAP. That's the Supplemental Nutrition Assistance Program. Participation erected by the state beginning in February. And without disabilities, the dependents can receive SAP benefits without working an average of 20 hours per week. 54,000 adults in 112 counties, including 20 where the time limits were placed before February. New data shows that 1 in 5 Kentucky adults who could lose their food assistance in the next 3 months. Let's see the date on this. This is November 14th. Let me finish down here. This is to 10,000 without many subjected to the work requirement are employed in low-wage jobs. We'll get to this in a minute. And the U.S. Department of Labor refers to these areas. This is labor surplus areas, which the federal government makes it easier for states to waive the SAP time limit on for such counties. And some of that, there are 56 of these labor surplus areas in the Commonwealth of Kentucky indicated there. This year, even while the state was installing time limits for some of those areas, this year was the first time the time limit barriers were in effect. It shows, and this is the other part now, this is the food assistance part, and not the other part now. Here we go also. Falling Medicare enrollment of further counters in need for cuts. Recent, this is on November the 12th. This is Dustin Paget. Oops. Recent claims of shortfalls in budget for Medicaid benefits. An unwarranted alarm based on misrepresentation of the budget numbers, further undercut by the fact that Medicaid enrollment is falling between January and September. Total Medicaid enrollment fell by 96,634. That's 6.7%. Not only has enrollment been steadily dropping over the past 8 months, but enrollment is below what the state had projected and used in its cost estimation that's in their budget. The state, through Medicaid enrollment, would average at about 1,427,445, and that's in fiscal 2019. As of September, there were 1,336,000 people enrolled in Medicaid. Approximately 90,000, or 6.3%, fewer than expected average there. This in itself is a very interesting situation here. Meeting in August, the state argued that in addition to expected enrollment growth, projections claim cost development during the last budget cycle led them to believe that Medicaid benefits appreciations were not enough to cover their bills. Medicaid benefits have actually decreased, since 2015. And there's a chart here. We'll pinch this particular situation here, and this is on their blog. And there's a continual misrepresentation. There's no doubt about that. Kentucky Medicaid enrollment is falling. It went from roughly 1,500,000 down to 1,350,000 and falling. So it is at 1,336,000 now. So you can see where this is going. It's actually going downhill and not uphill. Now here's the other part of this equation. Bear with me here, unfortunately. Looking at economic performance. This again is from the Kentucky Center for Economic Policy, and I'll just briefly go with this. Is by Jason Bailey. Kentucky and its policymakers need accurate indicators to measure the strength of the state's economy and to understand the impact of policies on jobs, the economy, and well-being. Announcement of potential private business and investment by the state cabinet for economic development. They were there in the Medicaid discussion. Cabinet announced sometimes involves little, if any, job creation. And that is more than just a problem in the Commonwealth of Kentucky. That is in many states. Recently, the state promoted the $9.2 billion in potential private investment. They announced that was in 2017. And a closer look at the revealed a substantial share of the announcement are not correct, connected to any new jobs. The total includes investments that may never occur. And this is a problem that in Wisconsin with a plant that they put in. This is all over the place. Announcements are not what they claim. And some more citing here. The Cabinet for Economic Development announced plans to expand and locate in Kentucky. Have received a considerable attention. The sum of the announcement was $9.2 billion. That's from the Blevin administration. In Kentucky's record-setting performance this year in jobs, and part of the problem is much of this literally never materialized. Period. It just did not happen there in Kentucky. In addition, not all the announcements will necessarily materialize. They cite one called Brady Industries that's in Greenup County is $1.3 billion of the $9.2 billion. The Courier Journal reported the company is far from raising the capital to build the $1.68 billion facility as of September. Brady was seeking a $1 billion federal loan, $500 million in credit from the county, and $400 million from a crowd fund, sales stock. So in other words, they don't have the money, and the company has a history of quote-unquote broken promises. So these are some of the things that are happening, and also around their right to work there. The actual situation is they have lost 2,319 jobs from various kinds of closings there in Kentucky, and I won't go into what they cite as evidence of that, but a Kroger distribution center, which is being established to serve many stores. Amazon's announcement of its $1,494 investment to open air cargo plant. I've received stuff from them before. And it will employ 2,700 people, 500 of which will be full-time. Now, Amazon has raised their salaries to $15 an hour. But on scale here, Kentucky has more than any state but California and Texas as far as their facilities. Plus, they have a customer service center there in Kentucky. Before the announcement, Amazon has 7,200 workers in Kentucky. That's according to the state. And as many as 10,000 workers according to Amazon. It's the fifth largest employer in the state of Kentucky. And a lot of that is based on, this is actually Louisville, Worldport facility, adjacent to Louisville Airport. DHS used to be there. We used to use DHS quite a bit. And the airport goes back to the 40s. In fact, they had to clear some landmines there. Part of a very, very strange situation. But what the Blevin people are taunting is their right to work law that passed in 2017. Amazon's announcement came only 3.5 weeks later. But it really didn't matter because Amazon is not organized, and Toyota is there, and Ford. But Ford has been there. Ford is unionized. Toyota is not. But they have a large amount of workers in that state that are in the automobile industry. Don't have the salaries listed here, but they do have a lot of lower salary type things. Since the federal minimum is still at $725, most all states have surpassed that. with the benefit package at 15%. This is a requirement at 2007 at $18. They have full-time worker to 3,000 whatever. This was to get the state aid single health care coverage. That's well, that they don't have. Workers at just 10% of wages make roughly $900 a month. They'll make a little bit more, and this is with the subsidies. The states give a lot of different subsidies there. 2007 report by the Center for Business and Economic Research, that's the University of Kentucky, estimates that the program cost $26,000 per associate job, a number much higher than the estimate of 2,500 jobs. This is at I'm assuming this is at was Amazon. Anyway, similarly, a report by the Anderson Economic Group in 12 found that 35% of jobs associated with tax incentives have to be created solely as a result of the state tax breaks. And this something goes to many, many states. The Amazon Air project received $40 million in tax breaks, in addition to jet fuel subsidy valued at $3 million, which required a special of the General Assembly. Bailey Industries also benefited from a unique $15 million direct state purchase of equity. I mean, all these characters are getting enormous amounts of money out of these states. The state's role in promoting economic development should primarily focus on consistent and a long-term investment in the fundamentals of creating thriving communities and supporting economic growth within those communities, a good education system, a modern infrastructure, and of a community support. And that's also what happens many times. The infrastructure is not there. The economic growth has, job growth has weakened in Kentucky. Down, we were looking at this earlier here, after the passage of this so-called right to work situation. Over the year, non-farm jobs in the thousands. Let's see what we have here. In October of 2017, I guess this is the latest we have. 10.4 is what they were able to get. In October of 2013, 2014, it was 30.9. So job growth has slowed. There's no doubt about that. And let me get to the conclusion here. It's important for Kentuckians to have the best information available. And again, it points back to this state cabinet here. And since 2009, Kentucky's inflation-adjusted median wage has increased only 0.4% year over year, and is 4% higher than it was in 1979 from 2015, 2017. Adjusted that, so it's fallen at 0.2%. So that's the story of Kentucky, and we'll go on to the presentation here. I wanted to grab the program itself with the people that are participating here. We did cover Arkansas. We did in a different program. We did Indiana. Okay, this was on Kentucky Tonight. And they had some airings there. Let's see, the next airing. They'll air this program also at 2 a.m. Well, it's already over. Anyway, they have one more airing tomorrow night at 5 a.m. That is on KET. That's Kentucky. And there, Renee Shaw is the person, and the people there, Dr. Alvarez, he was there. He's co-chair of the Medicaid Oversight and Advisory Committee. Is Dustin Puget, who was a policy and analyst there. And let me see, who else do we have here? We have Christy Roden of the Kentucky Cabinet for Health and Services. And of course, our own Mackenzie Cantrell. She is from Louisville. Very good discussion there. I look forward to it. Let me just do the sporting scores here. We haven't done them in a while. And see where the NBA was last night. Excuse me. Oh, where I am tonight. This is the curse of the broadcaster. On Tuesday night, the Trailblazers were in Houston. The Rockets won 111-104. The Suns were in San Antonio, 111-86. And the Raptors were in Los Angeles. Raptors 123-99 for the LA Clippers. At least we were able to do that. And we get a little break here. The Coyotes and Bruins pull out a game here, 4-3. The Kings and Sabres, and that's an overtime game. Sabres 4-3 over the Kings. The Maple Leafs and Hurricanes. Maple Leafs 4-1 there. And the Canucks and Blue Jackets. It was Canucks 3-2. The Red Wings and Capitals. It was the Capitals 6-2. The Panthers and Blues in St. Louis. It was the Blues finally win a game 4-3. The Senators and Predators. Predators 3-1 in that game. The Canadiens and Wild 7-1 was the final there. The Blackhawks of Chicago, our old friend Judy's team. And the Winnipeg Jets. It was the Winnipeg Jets 6-3, and the Oilers and the Avalanche. It was the Oilers 6-4. Now we have a little bit here, and the soap opera continues in Washington. We'll have that for another day. DJ Trump is still trying to find a chief of staff for there, and China and Hawaii. Anger, patriotism, iPhone boycotts, a lot of things going on there. In the UK, no confidence vote in the Prime Minister May. I suppose old May is out. I saw a picture of May arriving in Brussels, and literally the car door would not open. And old man McConnell is going to bring up the criminal justice bill. That's an interesting situation that will correct some of the inequalities in criminal justice. Finally, it's a bipartisan bill. The so-called black president Bill Clinton and his crime bill put more African Americans in jail than were literally in chains and slavery. He says, where is the time? And one white house said, as for weeks, has pointed out, the majority leader is facing a daunting end of the year thing to do, but the public they decided that where DJ Trump needs a win and he'll take the crime bill, he can't get anything else. Kentucky Republican, who is up for re-election in 2020, hopefully will not be re-elected, has not taken a personal position on the bill, telling reporters Tuesday that he is still reviewing the details. Trump said from the Oval Office, it looks like it's going to be passing, hopefully. Famous last words on a very bipartisan way. And it's really something we are very proud of. And again, tremendous support from Republicans, tremendous support from Democrats. That's DJ Trump talking there. Old man Grassley, he's from Iowa, as one of the sponsors of this bill. And Ted Cruz and Purdue, he's from Georgia, one-time skeptics to the effort, endorsed the legislation. So they're going to, and Dick Durbin, they're all going to run as fast as they can and get this bill passed. This will do it for us, Kentucky, and Medicaid. There's the title of the episode on the 12th of December 2018 from WBRN Radio and on the Boston Red Network. We, of course, always broadcast on Jerry Pippin Broadcast. Boof.
Good evening and welcome to Kentucky Tonight. I'm Renee Shaw. Thank you so very much for joining us. Tonight we're discussing Kentucky's Medicaid waiver. Our guests are State Senator Ralph Alvarado of Winchester, co-chair of the Medicaid Oversight and Advisory Committee, State Representative Mackenzie Cantrell of Louisville, Christy Putnam, Deputy Secretary of the Kentucky Cabinet for Health and Family Services, and Dustin Pugel, Policy Analyst for the Kentucky Center for Economic Policy. We invite your questions and comments tonight. Join the conversation on Twitter at KYTonightKET. Send email to kytonight@ket.org. Use the web form at ket.org/kytonight. Make sure to check the box that says you're not a robot, or give us a call at 1-800-494-7605. Please include your first and last name and town or county on all messages. Well, good evening, ladies and gentlemen. Thank you for being here. This is a very important topic, and we're so glad, Madam Secretary, that you could be here with us to help us understand the Medicaid waiver, and we'll also debate the merits thereof. But just to get everybody up to speed, in late November, there was reapproval of Kentucky's Medicaid waiver by the Centers for Medicare and Medicaid Services. How different or similar is the waiver that was approved from the original plan? And did you try to address some of those concerns about the reporting requirements, erecting barriers against coverage, and possibly even causing folks to lose coverage?
So there's not a huge difference. There were some very minimal changes between the original version that was approved January 12, 2018, and the one that was approved on November 20th. A couple of those changes are just there's a group called Transitional Medicaid Assistance that is not going to pay premiums, that we cannot require them to pay premiums. That was a good change that was caught by CMS. There's also an ability for community engagement, notification of at least 30 days, no less than 30 days prior to a community engagement going into place. And then there was also a not minor change, there was a change in classifying our domestic violence victims as medically frail status. So those were the primary changes that were in the new version. There's also some additional evaluation and monitoring requirements that will be for all approved waivers from this point forward. And then lastly, there was some additional language around just the actual evaluation and monitoring itself.
Right. So when you say community engagement, many people interpret that to work requirements, and I'm sure this side of the table does as well. So get your take on how dissimilar this is, and do you believe that it will lead to loss of coverage for possibly thousands of Kentuckians who've benefited from expanded Medicaid?
Sure. Well, like the Secretary said, there really are not many changes to this plan. So, all the conversation we've had over the last couple of years still carries forward. And I guess there's a new implementation date of April 1st, so there's some time to prepare for a lot of these changes in the meantime. But like you said, these reporting requirements really have a 20-year track record of showing that people end up losing, food assistance in SNAP or cash assistance in TANF. And they really don't end up any better off. And so we know that, these requirements take a lot of money to set up. They take a lot of bureaucracy to manage. And when you have, reporting requirements, you have a redetermination requirement, you have premiums, you have sort of these layered and sort of entrapping requirements that, the state has said will likely lead to 100,000 fewer people covered by Medicaid. I think that's a low estimate, honestly. And I honestly, I'm concerned about what this will mean for Kentucky, given all the progress we've made over the last several years.
Do you still stand by possibly 100,000 losing coverage?
Just a couple of clarifications on that. It was 95,000 projected, and that was from our actuarial estimate for the initial waiver. And during the course of our negotiations with CMS, there were a lot of changes made in safeguards and guardrails and assurances the state had to make. So, we don't, the only way to find out is to really go through the demonstration and implement. But we have had to incorporate a great number of assurances that there are guardrails, there are ways for people to get back into coverage if they are, in fact, suspended from coverage.
So we do want to talk about that, but let's talk about the rollout, because April 1, 2019 is when this comes into effect, but it phases in. Do I understand that correctly, regionally or by county? So who's up first?
Sure. So the community engagement requirement is the only portion of the waiver that will phase in.
Okay.
The rest of the benefits changes would be effective April 1st. And then we would have a phase-in of the community engagement requirements across the state by workforce region, beginning with one county, Campbell County, in northern Kentucky workforce region. We then would have an additional 2 months of rollout, during which time, and I think this is key, and my partners across the table would like to hear this too, we will have some dashboards that we will monitor daily that show us, give us early indicators if there are any concerns or any numbers that we should be looking at, and any reason for us to alter that rollout schedule. So we have a lot of flexibility, and I think that's one of the benefits of the approval.
One of the things we've learned, Dustin Pugel, you've written that from your data, there's about 96,634 folks that have rolled off of Kentucky's Medicaid program from January through September. Deputy Secretary Christy Putnam, you say that number is significantly lower, 54,500 or so. Regardless of the number, many people would say if that's happening, what's the purpose of the waiver? And I'll let Senator Alvarado jump in here.
Yeah, I think the purpose of the waiver is really, I've always talked about this when we first had this roll out. I think when we had Secretary Audrey Haynes years ago, which was here, I remember talking to her in Senator Julie Adams' office once, talking about what are we going to do to try to incentivize good behavior and disincentivize bad behavior. We see that with all of our private health insurance plans, and I think we've got to find a way to drive people into being healthier in their lifestyles. All of our private health insurance, yours and mine, probably offers some kind of benefits. If you quit smoking, you lose weight, you get your diabetes under control, you do lots of different things. Most of us already have that community engagement piece that we're working or trying to volunteer, and we know that those things are also positives in people's lives. And so trying to incorporate people that currently are able to work and that are not working and that are receiving those benefits, I don't see a problem saying, hey, listen, try to either go get an education. And these things aren't necessarily all work. It's trying to get you to learn new skills, to fill some of the needs that we have in the state. To provide volunteerism, education, those kinds of things, or they can work. Some of them are already working and already fulfilling those requirements. But a lot of it is also to push healthier lifestyles and incentivize people to do the right thing, that if they ever do roll over into private insurance, they'll already be used to those programs that are already in place.
So what's wrong with that, Representative Cantrell? It sounds like all the good things of trying to get people to be responsible, take charge of their health, and at the same time put some skin in the game when it comes to paying for some of their health care.
Well, there's certainly not anything wrong with incentivizing work. I think that's what we should be doing as policymakers, as legislators. The problem is, and the data bears out, that a lot of these recipients are already working. So when you have a large class of people who are already working, why are we subjecting them to this new type of red tape, really? The Deputy Secretary wears her red tape pin. I think they're supposed to be reducing red tape. They're not supposed to be adding red tape for low-income people. So the question is, why is this population of people who are working in low-wage jobs, who are unable to have their own health care provided for them by their employer, why are we making them get on a computer in rural Kentucky every few months and report why they're working? We're not asking for them to work. We're asking for them to report that they are working because we know they're already working.
So go ahead.
I was just going to piggyback off of that. I mean, we know that about 62% of expansion eligible folks, so folks who were on Medicaid after the ACA expanded Medicaid here in Kentucky, they are working, but they work in low income jobs. They work in jobs that have inconsistent hours and inconsistent schedules. And that's why I think CMS is so clear that we need safeguards because it's essentially an admission that there is harm that's going to be caused. I can very easily see somebody who is working in a restaurant who, gets sick and goes home and doesn't make those community engagement hours, loses her health care, and then ultimately ends up being worse off for, being able to stay in the workforce or find a job. In fact, in Ohio and Michigan, a majority of Medicaid expansion eligible folks said that because they had Medicaid, it made it easier to stay in a job, or it made it easier to go and find work. And so, I'm concerned that really we're just creating, these extra barriers to folks. And when you put barriers in front of people, they're going to trip over them, regardless of whether or not they're your target population.
Deputy Secretary Christy Putnam, I want you to give us kind of the nut graph here of what is required, 80 hours a month and those other things. And Senator Alvarado kind of mentioned that it's not all about work, that there's other ways to engage that could help one qualify and maintain their enrollment.
That's correct. It is 80 hours per month. It's 20 hours per week, but that is a cumulative amount. So if someone did not make that 20 hours in a week, like if that person in the restaurant got sick and had to go home and didn't make their 20 hours that week, it is a cumulative amount. There's also a about a 60-day grace period before someone would actually be suspended for not making those community engagement hours. But someone could volunteer. They could be in a job training program. Those individuals who are already working maybe part-time low-income jobs, there are resources available here for people who already are working low-income jobs who have the desire to get into maybe a higher skilled, higher paying job. And we know that we have plenty of those available in the state right now. So part of this is, yes, absolutely, we want to make sure that people who are working have that work hours counted and have ways to report that. The other part of this, though, is really engaging those individuals with our career centers and providing bridges to resources that they may have no clue are out there, like our Work Ready scholarships.
Mm-hmm. And so to get to the point about how they provide the documentation, they can do that online if they have some proficiency there, or they can go to a career center and do that, and somebody will walk them through that process. Yes. Are there other ways in which they could get support and help in supplying that documentation?
There are other ways. Our assisters have actually been trained in Citizen Connect. We will train anyone. We've said this. We'll train anybody who would like to be trained in Citizen Connect for that person to be able to help someone else log in those hours. We do recognize that there are some bandwidth issues out in the rural areas. And so, to the extent that we're able to identify other locations like our libraries, our public schools, we've even engaged our Family Resource Youth Services centers, and the coordinators stand very ready to help if that's one of the options as well.
Some people would say, Senator Alvarado, we're leaving a lot of money on the table from the federal government by going this route. What would be your retort?
I would say that part of the reason we've got this problem right now is because we've rolled out a system that's we know that from a report from when Governor Beshear first rolled out the expansion, we had projections of what it was going to look like as far as a cost for the state. And we knew that it would eventually cost us around $600 million over a 2-year biennium. And it's coming to that fruition. We're facing about a $300 million deficit right now for Medicaid. A lot of that is because we're having an obligation of paying in. When it was 100% federally provided for funds, it was great. I remember when we talked to the governor back then, we said, hey, this is going to cost us a lot of money. Well, if it doesn't work out, just get rid of it, knowing that he wouldn't have to deal with this issue because he was going to be out of office. Now that we're here, we're facing a situation. And if it was about kicking people off and just getting rid of Medicaid, the governor right now has the authority tomorrow to prepare a document in 2 minutes with a paragraph saying, I'm rescinding an executive order. He could sign it, and you have 400 and some odd thousand people will be removed, and that would resolve all those deficits. I think the governor's trying to find a way to make this a sustainable program. And ultimately, we do have a deficit that we're facing in this. The legislature hasn't had an opportunity to put this forward. We tried. I think it got through the House, got to the Senate. I remember being in health and welfare. I made the motion to move this to the floor and did not get the votes from members on the other side of the aisle who wouldn't vote on that issue. We couldn't get it to the floor for a vote. So we've got a situation. We've got an executive order. It's costing us a lot of money. It's going to cost us more money in the future. We've got to find a way to be able to get folks, if we can, into private insurance. And this is, I think, an opportunity for us to do that. We've got to find a way to cover the cost, which is making it really tough.
So we have a $300 million shortfall in Medicaid. Does this waiver get at that?
Well, first of all, there isn't a $300 million shortfall in Medicaid. When Medicaid came forward with that claim, what they were saying was essentially, we asked for this amount and you agreed to give us this amount. And what they did was they called the difference between those two a shortfall. But that's not a shortfall. That's just the difference between an agency request and what they were budgeted. If we did that for every agency across state government, we would say that we had a $4 billion shortfall over the biennium. So, I think we need to start with that understanding, first of all. Second of all, we also know that whether it's 54,000 or 97,000, both numbers come from the cabinet. I don't exactly understand the discrepancy. Mm-hmm. But in either case, that means you're saving hundreds of $1 million per year, anywhere between $400 and $700 million. And
how much of that is a state portion of dollars? Because we know that's a federal.
Right,
state.
about 20% of that would be state dollars when you look at the difference between what we pay for traditional versus expanded folks, and you sort of mash those together. Mm-hmm. So, we're talking, but the $300 million shortfall was also over a biennium, not, each year. And that was also with regards to both state and federal dollars. So, I think we need to be really clear-eyed about what that number was. And then we also need to be clear-eyed about what Medicaid expansion means in the state. I mean, by rolling back the entire Medicaid expansion, you would be giving up $3.5 billion in federal funds each year. And those are, dollars that go into communities. They pay for nurses and doctors. Those folks go out and buy homes and cars and groceries. So that money doesn't just, go into the pockets of insurance executives. That money really flows into the community, and it also pays for care. I think when we talk about Medicaid expansion, we shouldn't be talking about whether or not we can afford it. I think we need to be talking about whether or not we can afford it without it.
Mm-hmm. And the impact on rural hospitals, do we know what the impact?
Believe me, we want to, I mean, I support, I'd like to see expansion. Like I said, I made that motion to bring it to the floor for a vote. It's just that, the issue is, again, you've got to find it's going to be a matter of having to pay for that. And there is 10%.
Just because you cut people off Medicaid doesn't mean that people are all of a sudden going to get healthier. They're just going to resort to higher costs of care. They're going to start seeking care in emergency rooms.
Yeah. Are you concerned that emergency room use, Ms. Putnam, would increase because of the waiver changes?
We've had that raised. We haven't seen a significant decline in emergency room use with the expansion being put forth. I think it's really important to also consider that, sure, the easy thing would be to just roll back expansion, or so-called easy thing would be to roll it back, but that's not the right thing to do. I think we all agree on that. We have 400 some odd thousand people currently known to us in the system at various stages of where we could possibly reach out and provide some additional assistance to them. And just, real quickly to touch on the budget piece of it, there is a consensus budget that does show a gap in what's the projected spending at the current enrollment numbers, but also we have waiting lists for our 1915C. So we have a lot of great need in Medicaid.
Okay, you said something that I didn't understand.
1915C.
Yes, what is that?
Bureaucrat, I'm sorry. It is our Michelle P. waivers, our home and community-based waivers. Right. We have a significant waiting list and shortfalls and provider rates that have people have asked to be addressed for a number of years. So
was the Medicaid waiver built into the Medicaid budget?
It was not.
Was not.
And what was the rationale for it not being included or built in?
Again, it's through an executive order. So you have, if you do that and you incorporate that in there, and any governor can come in and say, hey, we're just going to signature and get rid of it. They have that ability and that power. It's never been passed by the General Assembly. And that's kind of a scary.
I think there'd be some due process concerns, certainly. It's very easy to give someone something by an executive order. It would be very, very difficult legally to take that away.
Yeah, and that's the thing. It's either which way. It's going to be, again, you have a Supreme Court that's already ruled on this issue. The citizens of the Commonwealth sued to say that the governor doesn't have that authority. The Supreme Court says, yes, he does. So if the Supreme Court's issued a judgment saying, yes, he does, I would think that they would say he can also remove it as well. So the key thing is, again, if you're going to be fair, at least, the Supreme Court that's going to have judgments on both those things, I would think it's going to be, if you can put it in place, you can remove it as well. And like I said, we try to get this done. Our colleagues on the other side said no and didn't want to bring this forward. So we're with a situation where a governor has a lot of authority on this topic.
Obviously, both sides did come together to agree to budget for it. And so it's in the current budget. We know that we can pay for it. And so both sides said, yes, this is something we want. It's something we can pay for, and it's something we're willing to put our votes on.
So I think everybody needs an agreement here that everyone's trying to make it survive and trying to keep it afloat. What you've got to try to find a way to do also is, it's a very expensive also revenue to be able to have 1.5 million people in the state. It's a huge amount of our citizens that are in this process, is to find a way to make it affordable. And so just like any other insurance company that's out there, they've put in plans to help people get healthier and do things to try to reduce disease burdens and do those kinds of things. Have all that. I think it's time to start taking our Medicaid system and start trying to make it look more like a private insurance plan. And I think this is the first step in that process in trying to get it done. A lot of other states, it's interesting to note, a lot of southern states are looking at this model to see what this does, to look at expanding Medicaid themselves who haven't done it yet.
And we'll talk about another southern state, Arkansas, that I know, Dustin Pugel, you've written about, and we'll talk about some of the comparisons there, along with some of the SNAP work requirements and how that may be able to draw some parallels to what Kentucky is doing. You are watching Kentucky Tonight. Thank you very much for doing that. And we were talking about Kentucky's Medicaid waiver. We appreciate you spending the hour with us. So let's talk about, Dustin, you've written and talked about some of the parallels between the SNAP program work requirements and what we've seen happen there, and what that could foreshadow in Kentucky's expanded Medicaid population, and also the Arkansas experience there. So if you can talk about those two things before we move on and get more in the nitty-gritty of certain areas.
Let's do it. We'll start with SNAP. Back in the beginning of the year, the cabinet decided to allow a reporting requirement in SNAP that's similar to the reporting requirement being proposed for Medicaid. Not exactly the same, but similar, to allow those to roll back into several counties. And so between May and I think it was September, which were the first months for which people could potentially lose food assistance, 10,000 out of 54,000 people did. And they lost it because they did not, adequately report. Now, it's true that we don't necessarily know why they didn't decide to do that, but we know that they didn't decide to do that, or that they forgot to do it, or that they did it inadequately. And so they were essentially no longer able to use that food assistance. And that was very meaningful. It's not a lot of assistance. It's $1.36 per person per meal, but that's very meaningful to them. It's meaningful to their communities. And so I think we can draw some parallels to a similar reporting requirement for Medicaid. Now, Arkansas built their entire reporting requirement off of their SNAP program. There are about 69,000 Arkansans who are required to report accordingly. And of those 69,000, about 15,000 actually have to actively report. The rest are exempt for a whole number of reasons. There are some automatic exemptions that sort of bring them off the books. So far, over the last 3 months, about 12,277 folks have come off the rolls there. They've lost coverage, and they lost coverage because they didn't adequately report. Only about 600 people actually actively reported anything. So, we're looking at, potentially huge losses in Kentucky if we follow suit. Like Arkansas, we have automatic exemptions. We have exemptions that you can ask for. But unlike Arkansas, we have a much broader range of folks who are subject to this, so 18 to 64 as opposed to right now only 30 to 49 years old. There are other ways that people can lose coverage by failing to pay premiums, which we've already seen examples of people coming off in Indiana because of that. And there's just more people covered in Kentucky. So we're talking about potentially, we've talked about 100,000 people, but I've seen estimates upwards of around 300,000 people.
So if those numbers if the situation that Dustin Pugel has described, if that does come to fruition where you're seeing more than the projected 95,000 or anticipated 95,000 that could, what would the cabinet do then? Would there be some adjustments made to protect those and to keep that further hemorrhaging from happening?
Obviously, we would want to take a look at anything significant that came forward, if we had some significant numbers right off the bat. But I would like to just talk a little bit about, what happens when people do roll off. It doesn't mean that they no longer have access to SNAP or access to Medicaid. Many of these individuals, and we won't know for 3 to 6 months because we have a lag time in our wage data in reporting, end up being employed down the road or having access to private market insurance. The other piece of it is that
most of them were already employed when they came off of it, though. We know that most folks are employed, and when they don't report about that,
yeah, we have about half.
2/3.
If we, looking at the system specifically, when we run the report, there's about half who are already working 20 hours per week or more. If they're working 30 hours per week or more, they don't have to report anything. And very much unlike Arkansas, we have automatic exemptions. So if someone has certain exemptions as we run through our eligibility system, they're automatically exempted from the community engagement requirement. Arkansas is not automatic.
Out of 69,000 folks were exempted from actively reporting in Arkansas. They were deemed to have met the requirement based off their income, and so they were automatically exempt. So we're talking about almost 3/4 of the whole population that didn't have to say anything in order to keep their coverage, even though they were subject to that. I would call that an automatic requirement.
We would have some similar numbers like that with the automatic exemptions. So, but we do, obviously we would take a look at what kind of information we're getting in. But looking at some of the SNAP numbers, there's some studies out of Kansas that show a year down the road, people's income in Kansas has increased by about 127%. Many of them have worked to a full-time, better paying job. They've improved their income more than a year later. Some of them have doubled their incomes. So I think, the important thing here is there needs to be time to implement, obviously to take a look at all different kinds of impacts that we're seeing, and then take into account and make some adjustments where necessary. But we really believe that the reporting requirements, the outreach we've done, we're not like Arkansas where we've tried to use a system that was already in existence. We've really tried to have built an integrated mobile-friendly platform that allows people to report from many different places using many different methods.
This comment from Percy Stone in Elizabethtown phone call. He asked, how are people supposed to get to their work requirement location when there is little to no public transportation available? I ride my bike, but when it's bad weather, I take the bus, which is $5 round trip and no longer operates on Saturday. He works at Goodwill for minimum wage, 20 hours a week. So can you answer Mr. Stone's concern?
There are exemptions, both temporary and longer-term exemptions for someone who's experiencing issues in transportation, for someone who may be experiencing an injury or illness. So there are some protections for individuals who do have temporary hardships like that. For someone who's experiencing a longer-term circumstance, like a challenge in a rural area where there is no transportation, that can be a longer-term exemption as well.
This other question in a web form from Mick, I hope I'm pronouncing this right, Clark from Louisville. The storyline of incentivizing good behavior and disincentivizing bad seems logical, but why do the conservative leaders think just being poor alone is bad behavior that needs these punishments and extra hoops, but being wealthy deserves the tax cuts they gave? And I'll let Senator Alvarado answer that.
I don't know that I necessarily agree with that. It's always kind of a bit of a loaded question the way he's asked that. But I think, I think again, the idea of incentivizing, like you mentioned, and disincentivizing bad behavior is nothing new. I mean, that's what we have to do to kind of make health care affordable. Whether you're wealthy or poor. I think a lot of the issues in the state remain the same for a lot of individuals. We use a state employee health plan, which are a lot of people that work across the state. They have a lot of innovative ideas that we've incorporated from their plan.
And this is very similar to how that functions, correct?
Very, very similar. I mean, we have, I'm trying to increase a lot of transparency. We had a lot of discussion in the green room prior to this about a lot of things that we're trying to do. There are patient advocacy issues to make it easier to shop for your health care and do some of those things. But I think we're using a lot of the ideas from the state employee health plan, which has done a very, very good job, both with diabetes management and smoking cessation and exercise and a lot of those kinds of things, and having to bring some of those concepts to some of the folks that are in Medicaid. And a lot of folks, I think a lot of them want that opportunity. I think we need to merge the needs that we have in the state right now, where we have a lot of needs for employees to be able to get out there and be properly trained. I think a lot of people, if they lack that, this gives them that opportunity, that impetus, where we'll cover you with Medicaid, get that education, then hopefully get a much higher paying job. So if the individual thinks of someone who's doing one of those jobs is wealthy, I say let's get them into those kind of roles. We have a tremendous need from our employers across the state for that.
And from the other side of the legislative aisle and hall, literally down the other end, your retort to that, Representative
Well, if we're talking about whether there is a $300 million shortfall in Medicaid currently, when you look at the tax bill that was passed earlier this year, the revenue part of that, I think is what the question's really getting to is you had corporate and higher income taxes cut at approximately $500 million. You had a tax shift where you had a new tax on services placed on a lot of working class type services at the tune of raising about $250 million. Well, there's your shortfall right there. And we haven't, again, Senator Dr. Alvarado has pointed out that we haven't had the opportunity to do a lot of legislative action in this area, but we do create the financial insecurities around, the cuts that we could be adding people to Medicaid if we had the money. Budgets are about where you place your priorities. It's not about how much money you have, it's where you spend it.
Mm-hmm. I want to say something, too, about incentivizing and using Medicaid as a way of incentivizing people to work more. I want to start by saying Medicaid is already a pro-work program. It enables people to work. I mean, I've heard lots of stories of folks who, were sick, were on Medicaid, got better, and were able to either stay in their job or get a new job. What is an ineffective solution to trying to help people get to work are these work reporting requirements. So in a study of 11 different cities that had these for SNAP and TANF, they followed them years down the road, and most people...
SNAP being food stamps, TANF being...
That's right, exactly. TANF being cash assistance for very low-income mothers. These folks did not end up any better off than their peers who didn't have these requirements. In fact, in some cases, folks who were on these programs ended up in deeper poverty than their counterparts. And we were talking about the Kansas study in particular. Yes, some people did end up better off, but 4 years after they were sanctioned for this work program and lost their cash assistance in Kansas, only 2 out of 10 ended up with wages above the poverty line, and the median wage for folks in this case was 11% of the poverty level, which is $2,175 a year. 1 out of 3 of them had no income at all. And so if we want to talk about a policy that has a 20-year track record of incentivizing work, these work reporting requirements are not that policy. Now, there are other opportunities that we have. The state has been very aggressive at expanding a SNAP E&T program, which stands for Employment and Training. So if you have food assistance, you can voluntarily take advantage of certain programs that help, push you along in your skills and in your employment, and people can avail themselves to those. I think, it's got a slow start, but it has a lot of promise. There's a program in Montana that's been incredibly successful at empowering people to earn higher wages. But if we want to talk about effective policies at incentivizing good work for good jobs for good pay, this is not the way to do it.
Yeah, I think I know where she's going to go with her comments. I can tell she's chomping at the bit to say the same thing I am. This is about people that are able-bodied without dependence. This is not about moms who have kids or have anything along those lines. These are people who are currently not working.
No, they currently are working.
These are people that are working or currently not working, but able-bodied adults, either which way, you're right, could either be working or not working, but able-bodied without dependence. These are the individuals we're talking about. And I forget the total number of individuals we're talking about in that regard, but a lot of them are unemployed individuals also. So it's a matter of getting them the skills for those kinds of things. We're not talking about kids or people who have dependents or anything along those. It's 350,000 people. I mean, we're talking, and the stat we're using is that 62% are already working. That means that 38% of them are not.
Because they're ill or disabled, they're students, they're retired.
None of those would apply
exactly.
to that. None of that would apply.
So we're talking about an enormous number of people who are already working, who could be sanctioned for failing to meet a reporting requirement, losing their coverage, and potentially being caught in a situation where they can't work because they've gotten sick.
The reporting requirements are not so burdensome that someone couldn't enter. I mean, we all do our car insurance online. Most individuals, have smartphones and are able. That's why we made it mobile enabled. And I think one of the things that's faulty in this discussion is talking about welfare programs from 20 years ago where there weren't supports built around, there weren't pipelines built in, there weren't 2 years of outreach that has gone into creating these opportunities. I mean, the intention is not just to get people back to work or put people into low-income, minimum wage jobs. That's a failure from the start. The intent of this is really to take those opportunities that are out there, connect people with them meaningfully, and walk with them along the way while they go through this process of going from either underemployed or unemployed into a place where they are able to get that additional training, they are better able to support themselves, they are able to meet those reporting requirements, and it's not a barrier to them any longer that they're working in this low-income job that doesn't have a future for them.
Those same opportunities are available to folks in SNAP today, and yet we know that they're rolling off by the thousands each month. And so folks are having a hard time affording groceries, they're not putting as much food on the table, and yet at the same time these opportunities for education and training and furthering and advancing their own careers are available to them. So I don't know why our Medicaid program would be any different in that regard.
Jason Dunn from Frankfurt, who I think is affiliated with Kentucky Voices for Health.
That's correct.
I'm glad he certified he's not a robot.
That's good.
Well, he made it that far in the web form process. He says, on the Kansas example, what happened during the same time period in Kentucky when there was no work program and the SNAP program? Kentucky's caseload declines 25% as people went back to work. The economy is the main driver. So this side says yes, and this may not disagree with anything Mr. Dunn had to say there.
An improved economy is always going to lead to more people rolling off.
Right.
And again, so part of what we're seeing, and there is a big difference between our SNAP benefits and those SNAP benefits that we're talking about that people have rolled off of in the past few months. Those are only the able-bodied adults without dependents. Again, that group of individuals, the SNAP benefit for those individuals it's meaningful to them. I don't mean to discount that, but it is not as significant as a Medicaid, benefit, a health insurance benefit where you're talking about, several $1,000s worth of insurance coverage, of health coverage that you have. It's not insurance, but it is coverage.
Right.
So, one of the things is that is more of we're hoping that that's more of an incentive for individuals to say, and we've talked with a lot of these individuals through we've done an in-depth citizen engagement process where we've actually gone out, we've interviewed individuals, we've interviewed businesses and partners and community agencies, I think some of your colleagues as well, to say, if you have the choice to get plugged into a training program that counts for your community engagement, that would lead you to a more improved situation, would you be willing to take advantage of it? And most of the individuals responded absolutely yes, but they aren't sure where to look, they're not sure where to ask. Who to ask. And so I think there's a myth out there that individuals, are already working and they're okay in a place with a lower income job, but they're not aspiring to do something different. And that's really what we're talking about, is working with people on those aspirations to move to a different place where those benefits are not the difference between, being able to put groceries on the table. It's a more meaningful difference.
And I think the fact that, as the economy has been slowly improving and people have been coming off shows that when people have the opportunity to work more, when they have the opportunity to earn higher wages, that they do that. And I don't know that, these extra incentives are the right way to encourage people to, further their careers and provide more for their families. I think that it's very natural that folks want to work. They want to work hard. They want to earn a living. They want to provide for their families. And I think that these enrollment figures are really showing that in real time.
And I don't think that economic opportunity is necessarily geographically homogenous across Kentucky. I'm really fortunate to serve a district in Jefferson County where you can really feel the economy is getting better. And if you want a job in Jefferson County, you know, it's like a lot we hear from a lot of business owners. If you can pass a drug test and you can show up on time, you know, you can get a job making, you know, $10 or $12 an hour. But I won't name names about any of our rural counterparts. But, you know, if you're the gentleman who dialed in who needs to ride his bike, and that bike ride or car ride could be 40 minutes to an hour. And I think sometimes those people are driving to jobs that pay lower wages, but they're happy to have them. But there may not be a path to advancement, and there may not be a path to advancement that doesn't require more, you know, education, that, you know, you work a long day at a low wage job and then you go maybe the other direction to the community college. You know, there's a lot of factors at play at that.
You are watching Kentucky Tonight, and we're talking about Kentucky's Medicaid waiver. Thank you for joining us. I want to talk about some of the questions that we hear a lot about when it comes to the definition of medically frail and the determination of that classification. Who decides that? And if someone is denied to be deemed medically frail, what's their recourse? So, Secretary Putnam, help us understand this, please.
Yes, so medically frail status can be a physical or mental condition, or it can also be a condition of being chronically homeless.
Which means they're exempt from the community engagement piece.
They're exempt from premiums and from the community engagement piece. They automatically get the Medicaid state plan, which means they get full benefits, they get vision and dental, and everything is covered. Medically frail status, again, is the policy is set by Medicaid, Department for Medicaid Services. The managed care organizations are charged with carrying that policy out, and our actuaries have built a tool that sits in our claims database, and there are a number of different debilitating conditions, diseases, you know, advanced diabetes, cancer, those sorts of things that automatically, if someone has claims of those sorts, they can be automatically deemed medically frail just by having that history, that medical history. If someone is either new to Medicaid or they've maybe been newly diagnosed with a condition like that, they don't have that history built up. So that is where a provider attestation comes into play. So
provider attestation means what, essentially, in layman's terms?
It is when you go to a doctor or other healthcare specialist and they they complete a survey, basically, that is also, it's coded. I mean, there's not a way for it to be subjective. It's very objective. And they are able to determine and sign their name, you know, like Senator Dr. Alvarado would see this individual and sign his name attesting to the fact that this individual has a condition that causes them to be medically frail.
Right.
The problem with the attestation process in particular is that it's a 7-page form. It's got 10 pages of instructions. It's very complicated. Now, I think that it needs to be thorough, and I appreciate that the state has to go through that because there's certain federal regulations that have to be met in order to make sure that happens. But what we're hearing is that, A, doctors are not wanting to fill out forms in general, let alone a 7-page form with 10 pages of instruction. And B, the MCOs are getting forms that are of such low quality.
Managed care organizations.
That's right, the managed care organizations that are responsible for actually providing Medicaid, and the ones that have been sort of tasked with this process. They're getting forms back from doctors who are, you know, doing this quickly because they have 1 million patients, they've got a lot to do. And it's of such low quality that they're not able to actually approve them based off the guidelines that they've been given. We also know that, you know, there are sort of ways in which you have to answer it, and there's a certain sort of point total that you have to get in order to actually be considered medically frail. But, you know, those are different for different kinds of conditions. Using substance use disorder as an example, you know, if you are in residential treatment, you're basically going to be considered medically frail in general. If you have a substance use disorder, though, that's current and you're not actually getting treatment for it, you probably won't. That's the first problem.
Maybe counterintuitive.
But the other problem is, you know, you're also requiring people to report to the government that they have a drug problem.
Yes.
And locally on the ground, you know this, Renee, State Representative Joni Jenkins and I started a local opioid task force in our home communities back in Louisville, and we have seen firsthand from our own constituents the you know, all of the emotion, all of the pain that comes with having a loved one who has substance use disorder, and anything that our state can do to keep these people from falling through the cracks. We need to do it. We need to put, you know, as few, at least regulatory burdens in their place as possible. And I'm so worried about these people under that sort of criteria. I don't know very much about the assessment, but I know why it matters. It matters because this population who may not get in front of a provider for a long time might be on a traditional expansion, maybe failed to meet the reporting requirements, gets locked out for 6 months. And then where are they? They think they can't go to see a provider when really they were medically frail all along. They just weren't. It was a paperwork problem. And these people are more than a paperwork problem.
We are just as concerned as everyone else is to make sure that the appropriate people get determined medically frail, because if they don't, and if they do fall through the cracks, they will fall through the cracks as non-compliant when really they were compliant, to your point. It is also something that it skews our outcomes. It doesn't show the effectiveness of the demonstration waiver if we aren't properly identifying our medically frail individuals. So we are very keen on making sure that we continue to work on the process. You had asked about if someone feels like they were not appropriately determined, if they were medically frail and weren't determined to be so. There is appeals. There's an appeals process that first goes through the MCO, but there's a traditional appeals process that it would follow through the department. But again, we are looking at ways to get additional information out, to put together a webinar that's available to providers, and to work with providers too on, if you have someone who they're not going to be covered if they don't get determined that medically frail status. I think it's a matter of really educating our providers on what that form really means.
And you're sitting by a provider, so perhaps you can chime in here.
I'm not going to say that doctors like filling out paperwork. We hate filling out paperwork.
Yes.
But there's plenty of federal FMLA paperwork. We get those requests all the time. They're very lengthy.
Family Medical Leave Act.
Medical Leave Act. People that want to have to take care of loved ones. We do that all the time. Department of Transportation, CDL, which are truckers, physicals, basically. Those are cumbersome and long. Physicians do them anyway. I think it's just another form that gets introduced. I know that doctors will always groan at having to fill out paperwork. I know I do, but we do it nonetheless. And I think even with drug treatment programs, plenty of people that have Casey's law evaluations. I volunteer to do those in my community in 2 of my counties for people that have those done. A lot of docs don't want to fill those papers out either. But sometimes when they just get accustomed to using them and they use them, they know what to fill out. It doesn't get quite as difficult. So,
and Casey's law is forcing treatment. I hate to say it that way. Yes, for substance use
so
disorder.
for individuals where they think someone's at risk and potentially going to die, it forces inpatient treatment for a lot of those individuals. So there's a lot of papers that we fill out for the government and people, obviously, as far as people having to report that they know that they're, drug addicts. We have a needle exchange program of any type. I mean, people come forward to government and say, hey, I've got an issue. It gives us an opportunity for that back and forth on that. But so, it's never fun to fill out papers, but they are required in order to keep things, I think, sometimes honest in the system and to make sure that people are going to fulfill those requirements and meet those requirements. And it often leads to discussions amongst providers, too, to say, hey, we've got issues here. If you think you're medically frail, they may not be. The doctor may not consider them that way. To lead to a discussion as to why that is. And do they have other needs that they have out there, too.
And there's been conversation about those who deal with mental health conditions, whether that's severe or persistent. So what are they also considered medically frail, and would they also go through the same process we've discussed for those with substance use disorders?
They would go through the same process. A lot of the policy that we've built around the medically frail process, we've actually done through conversations with stakeholders and providers. We've gotten input, for example, on the original chronic homelessness was using the HUD definition, and we had some conversation with a number of different
housing and urban
groups.
Development.
Yes, thank you. Sorry.
That's okay.
That description was too strict, was too stringent, and would allow too many people to fall through the cracks. So we agreed. We expanded that definition for chronically homeless, and I don't know it off the top of my head right now, but made it less restrictive so that we make sure we are capturing the right people in these places. And there are some self-attestation where people can say, I consider myself to be medically frail. If they determine
domestic violence survivors,
domestic violence survivors are automatically considered medically frail for 12 months. Interpersonal violence and domestic violence. Right. Someone who has activities with daily living that's another reason someone can self-attest to being medically frail.
Activities of daily living.
Difficulties with activities of daily living. Thank you. That's another reason that someone can self-attest to being medically frail and get that status automatically for 6 months. So we've really
there's no other further documentation needed other than a self-attestation, right?
For the initial 6 months.
For the initial 6 months, okay.
Yes. Still a lot of personal information to have to tell the government, though.
Sure. And then after that, beyond that, what's next?
Beyond that, it would be going to a provider getting some sort of determination that they are having difficulties with those activities.
Any issues with any of what Secretary Putnam has just laid out when it comes to either those with severe or persistent mental illness or domestic violence survivors or others who would be deemed or could be deemed medically frail?
I think the state has put a lot of thought into it. I've not followed the medically frail process as closely as folks like Dr. Sheila Schuster and some others. What I've heard is that, it is a very burdensome process. It takes a lot to be able to do. Now, there is a self-attestation opportunity that protects you from a lot of these requirements, at least for a time. But I'm also hearing that there's a lot of, conflicting information around some of the particulars. I think the real important thing to consider here is that we keep talking about protecting people from the waiver using these, self-attestations, medically frail determinations, and different kinds of exemptions. These are not, parts of a plan that are designed to sort of roll out the welcome mat to good coverage. I've heard Joan Alker from the Georgetown Center on Children and Families call this the unwelcome mat, and I think that's true in a lot of ways.
But I would have to disagree with protecting people from the waiver. What the medically frail status is it's a federal requirement for any state that has an alternative benefits plan as part of its Medicaid coverage. We are required to have an exemption for medically frail status that continues that group of individuals in the full Medicaid state plan benefits. So it's not a protection from the waiver. It's actually a federal requirement that that exemption exists to continue those individuals with full coverage. And we certainly agree that those individuals who are medically frail should have that full coverage.
And I just want to make sure I'm clear, and hopefully this will clarify for viewers too, that the managed care organizations make the determination about medical frailty. That's correct, right?
They have the actual process. They use the tool that's in our system, that's in our claims database.
So the state health and family service cabinet has given the MCOs this information that they must use to determine medical frailty.
The same tool sits in the claims database that is the state claims database, and the managed care organizations submit those claims that they have for those individuals against that claims database, and the tool actually determines based on the claims history. So it's established by Medicaid, but it's used by the managed care organizations.
And so the appeals process goes through the cabinet or through the...
Ultimately through the cabinet.
Right.
Yes.
Okay. Just want to make sure. It's a lot to take in here. We want to make sure we provide as much clarity as possible. So January 1st, there starts copays, correct?
That is correct.
So explain to us then when the premium process someone can change over to premiums. So this is where I'm a little fuzzy as well.
So the copay, the initiation of copayments is a completely separate topic from Kentucky Health. So I first want to make that point of clarification, is establishing the copays. The managed care organizations have always had the ability to collect copays. They've chosen to waive collecting copays. We charge copayments for our people who are in traditional Medicaid, who are in the state plan fee-for-service, individuals with disability or those sorts of things. They have a copayment system now. This is just extending that same copayment system to those who are on expanded Medicaid. The big change that we have is we have exempted all children from copayments. We've eliminated all of those copayments, so no children in Medicaid services would have a copayment. When you switch to the premium part of it, that's when Kentucky Health goes into effect April 1st. Right. The default will be to a monthly premium payment. And the reason for that, so if I'm in Medicaid and I'm an able-bodied adult without dependents and I change over to the alternative benefit plan known as Kentucky Health April 1st, I will change from having a co-payment every time I go to the doctor to having a set monthly amount that is a premium payment that covers all of my medical expenses for the entire month.
And typically the premium amounts range from what to what?
$1 to $15 per month, and that is for family coverage.
And that $15 is the maximum?
It is.
Okay. So it increases every year. Well,
after the first 2 years, yes, it will start increasing to a maximum of $37.50 for family coverage.
You mentioned a moment ago about how you've made this site very mobile friendly, because I think that may have been some of the concerns in maybe Arkansas about, or other states, that the website wasn't, because most people who are of certain limited means, they don't have desktop or laptop Apple MacBook Pros.
No, they have a phone.
They have a phone.
Or smartphones.
Or smartphone. So other than the career centers, I mean, the mobile device that this is going to be April 1st, this is going to work. They have to have set up an account by April the 1st?
Most of them have accounts. If they have logged on to Benefind for their benefits services, they've already established through what's called Kentucky Online Gateway. They've done their identity verification. They already have an account, and they should be able to use that same account to log on to Citizen Connect. And it has been in effect. It's been operational since January of this past year because we've been using it through the career centers for the SNAP employment and training services.
Okay.
Can we jump back to premiums and copays
Sure,
just
absolutely.
for a minute? Because I really was hoping we would get to that. We've spent a lot of time talking about the community engagement reporting requirement, and I don't think we've paid a lot of attention, just generally, not here tonight, to what happens when you start charging low-income folks premiums. So if you earn below the poverty line, you charge a premium, and folks miss 2 premium payments, and then they get switched over to copays. They don't lose coverage. But if you earn above the poverty line, then you do get locked out of coverage. Now, there are on-ramps. There are ways people can get back on, but we know from SNAP that doesn't happen very often. I think 34 people who have been sanctioned because of the SNAP reporting requirement came back. What we know from places like Indiana and Oregon and others where they started charging Medicaid enrollees premiums is that people lose coverage. In Indiana, 55% of people missed at least one premium payment. There were 60,000 out of 325,000 of those who earn above the poverty line who were either never enrolled in coverage because of that or were kicked off of coverage because of that. And I think, when you add that to the redetermination requirement, to the reporting requirement, you really see a lot of ways, a lot of hoops, so to speak, that people may not be able to jump through in the end. And so, there are opportunities for people to make third-party payments, to make premium payments on behalf of somebody. But again, using Indiana as an example, that doesn't happen very often. It happens, but it doesn't happen very often. And so I'm, concerned that we're going to end up in a similar situation here as we start, these same things. Premiums typically reduce enrollment, and copays typically reduce utilization. And I think it's, it could be wise to have co-payments for certain specific targeted services that you don't want to be overused, but to have co-payments for a broad swath of services is a little more concerning.
Because I think the assumption is if you have people who are on the expansion population who are making more than 100% of, or at least
between $12,000 and $16,000
a year for one person.
For an individual.
I think for 133%, I think it's $16,000 for one person. The assumption is they're above the poverty level. They have some sort of income. They should be able to put it toward their health care. I have a constituent who paid the premium during this first attempt at this rollout over the summer. And what I found out from her was she really couldn't afford to pay it, but she did have a credit card, and she was able to put it on the credit card. So really, we're taking a financial and social safety net like Medicaid, and we're increasing the financial burden of Medicaid recipients, which is what Medicaid is supposed to lift that financial burden. So
which it does. I mean, we know that it's really reduced bankruptcy for folks who end up with a lot of medical debt, and before, but now don't really have
before
that because
the ACA,
they have financial
over
projections.
60% of bankruptcies were from unexpected medical expenses.
And there was a report just last week from City Labs that showed that people are able to stay in their homes because of this, that they're able to pay their rent checks because they don't have medical debt or medical bills that they have to prioritize. And so, if you want to talk about, really effective social determinants, Medicaid provides for that already.
But I think if you want to talk about really sustainable long-term programs and long-term sustainable lifestyles, you really have to take a look at, where is that funding going to come from 5-10 years from now? We can't perpetuate 450,000 people on an expanded Medicaid program indefinitely. I mean, it's just, the money is just not in the state budget unless you know of something that I don't know.
It's counter-cyclical, though. As the economy improves, as we've seen, that number is going to go down. And then when we need it, when we hit a recession, that number is going to go back up. And that's why the federal government provides so much money for it. And that's why also during, the Great Recession, the federal government typically provides more money like they did for CHIP to make sure that there's not added burden for states. So I know you can't always count on the federal government to do the right thing, but I think for the most part, when it comes to programs like Medicaid that are such an important economic program, that are such an important health program, we're not going to end up, being worse off for this. I think the real question is, can we afford not to have it?
I want to touch real quickly on the dental and vision benefits, which would come underneath a My Rewards system. Is that correct?
That is
so talk
correct.
about what My Rewards is, another incentive, and you can earn dollars, benefits, services by doing various things that would then enable you to take advantage of vision and dental
You can,
services.
and so the My Rewards account it's a health spending account. It's like a health spending account. This was modeled again after the state employees health insurance plan. My health insurance until this year did not come with a vision and dental benefit option. So I would put actual dollars into an account and use those dollars toward my vision and my dental services. For individuals who are in Kentucky Health who have a My Rewards account, what they would do is it does incentivize healthy behaviors. So if they are participating in substance use disorder support services, if they are in smoking cessation, there's a very long list of qualifying activities, including some community engagement activities too, all of which are intended to encourage healthier lifestyles. Virtual dollars are deposited into that individual's account, and they can then use those dollars for their flexible spending, their vision and dental benefits. Down the road, we'd like to add fitness activities and possibly some over-the-counter medications and supplies. But that is the idea. And what we intend to do, because we do view the health of Kentucky holistically, is some of the things that we're looking at, like the free care that we're adding in the schools. When children are getting health care services, the adults in that household tend to be a little bit more engaged with actual health outcomes. And so looking at connecting some of those activities is something we'd like to look at down the road as well.
Any concerns about that? Were dental and vision ever included just part of the package? They are currently.
They're optional benefits.
They
are optional benefits.
Yeah, the state's not required to include them, but the state has included them for as long as we've had Medicaid expansion. I don't have any problem with healthy behavior incentive programs. I think most plans have them right now. I question, I think they have a mixed record in terms of actually changing behaviors. But what I am concerned about is taking away comprehensive dental and vision coverage. And when I say comprehensive, I don't mean generous, because it doesn't cover a ton, but it does at least provide coverage. When you take that away and you replace it with an opportunity to earn back specific services, you no longer have dental and vision coverage. And when California got rid of dental coverage in the mid-2000s, dental pain-related ER visits jumped 63% the next year. And so, I don't know that that's going to happen here, but I do think that there's evidence to show that, we could be in a dangerous position.
Well, we'll have to leave it there, Senator Alvarado. I know you want to chime in.
Indiana's done that, and it's actually worked well. It's really incentivized people up there. We're the worst in exercise in the country.
We're 45th overall health outcomes.
We'll follow up on this, I'm certain, during the session and beyond. Thank you all for being here. I appreciate it.
Thank you very much.
Thank you.
Be sure to join us next week on Kentucky Night when we'll talk about education issues, including high school graduation requirements. And catch Comment on Kentucky Friday, 8/7 Central. Thanks for watching. I'm Renee Shaw. We'll see you next week.